Good afternoon, everyone. Thank you for joining the TxRx Echo, brought to you by the Center for Substance Use Training and Telementoring Center, also known as CSTAT, by Be-Well, Texas, in collaboration with the UT Health San Antonio Echo program. Welcome to those that are joining us for the first time, and welcome to those that are returning. My name is Angela Riley. My pronouns are she, her, and I will be the facilitator for today's session. A few housekeeping items before we begin. To help us with attendance, please enter your full name, affiliation, and email into the chat. Please do remember to stay muted unless you are speaking. We do encourage using the chat and/or the raise your hand feature to pose questions and share perspectives throughout the session today. If you are having connection issues, please privately chat Karen, our awesome Echo IT, for further assistance. And as a note, these sessions are being recorded and will be shared on our website. Therefore, to ensure privacy, no personal health information is allowed at any point during the session. And this includes things such as names, addresses, birth dates, and other identifiable information. At the end of our session, the Echo team will send out a post-session survey. We kindly ask that you complete it, as it provides us feedback on how to refine these sessions to better address your priorities and your interests. Finally, Echo is an all-teach, all-learn environment, and we do encourage everyone to participate in the conversation and raise questions throughout the session today. And let's always make every effort to continue having this space, a space that is respectful and safe for all of us to learn. So with that, we will move on to some team introductions. I will begin with Dr. Shorter.
Hey, good afternoon, everyone. I'm Daryl Shorter. I'm at Baylor College of Medicine in the Department of Psychiatry, and I'm also the director for our Addiction Psychiatry Fellowship.
Thanks so much, Dr. Shorter. Dr. Walker.
Good afternoon, everybody. Crystal Walker, doctorally trained PA, and I am the director of the Substance Use Department, Clinical and Medical Services for My Health, My Resources of Tarrant County in Fort Worth. Welcome, everybody.
Thanks, Dr. Walker. Dr. Kowalczyk.
Hi, everyone. Alicia. I'm here in Baylor Family and Community Medicine, Addiction Boarded as well, and Medical Director for Santa Maria Hospital.
Thanks, Dr. Kowalczyk. And our lead specialist for today, Dr. Chowdhury.
Hello, everyone. I'm Ali. I'm one of the assistant professors at the Be-Well Institute on Substance Use and Related Disorders here in San Antonio. And I am also an adolescent addiction medicine provider.
Wonderful. Thank you, Hub team. We'll move to our presenters for today. Our case presenter will be Dr. Rezada.
Hi, everyone. My name's Miles Rosada. I'm a physician at Olive Branch Recovery here in Texas. I'll be presenting a case today about a patient that we recently had in our clinic with issues with cannabis use disorder, and just kind of some of the issues it can bring up with patients.
Thank you, Dr. Rosada. And our didactic presenter for today, Dr. Jacob Mumm.
Hi, I'm Dr. Mumm. I'm also with Olive Branch Recovery, and we'll be talking about telemedicine today.
Wonderful. Thank you. And thank you to everyone else that has introduced themselves in the chat. Please continue those introductions as we move on to the next portion. With that, we will go ahead and get started with our didactic presentation. Dr. Mumm, you may take it away.
All right. Well, like I said, I'm Dr. Mumm. I'm with Olive Branch Recovery. We started our clinic like right at the beginning of COVID, so it was very interesting. We kind of everyone had to find a new way, and so we went pretty much forward with telemedicine treatment for substance use disorders. So we'll talk a little bit about that today. Let's see. Can everybody see this screen okay? Yeah.
Yes,
okay,
that looks great, Dr. Mumm.
Great. So today we're going to talk about some recent research findings on the effectiveness and utilization of telemedicine for OUD. We're going to talk about key strategies and best practices for gathering and meaningful data during telemedicine encounters. And we're going to talk about different care models being implemented to support substance use disorder treatment through telemedicine. And then we've got some practical steps that pretty much anybody could implement in their practice if they would like. I have no relevant financial relationships with a commercial interest to disclose, and these are my opinions. And I would like to say this is the way that we found. There are many different ways to reach patients with substance use disorders, but this is kind of our take on it. So, first of all, why do we want to treat substance use disorder, right? It saves lives. It saves lives. Most of us got into this because we wanted to help people. There's a huge burden on the community. According to SAMHSA, over 48 million people experienced a substance use disorder in the past year, and substance abuse costs the nation approximately 510 billion with a B dollars every year, and that includes alcohol, tobacco, and drugs. And it's a significant burden on individuals. You or a loved one, you may have experienced this, these effects on your life, and so it's important to remember the individuals. Rural America is a treatment desert. This is a huge problem, right? Rural areas bear a heavy burden of substance use, and treatment is a lot of times hours away. The problems include a lack of anonymity, stigma, and transportation. And I don't know if I have to tell you guys, but Texas is enormous. According to the OMB, Texas has 26 metropolitan statistical areas, but 83% of Texas's land is classified as rural. This is farms, ranches, deserts, forests. Many of our patients live outside of the metropolitan centers, and so they can't easily see a provider who treats substance use disorder. So why telehealth then? Because we can reach these people in rural areas. I mean, it's literally a phone call away. The rural areas, they lack resources, they lack transportation. Sometimes a patient needs a little anonymity to get help because they don't want the other 25 people in their town to know that they have a problem, right? So what does it, is it effective? Is telehealth effective? So we're going to talk about 3 recent studies that have shown that telehealth delivery of medications like buprenorphine is just as effective as in-person care, but sometimes with better engagement and lower no-show rates. So let's look at a few. This article from the Journal of Substance Use and Addiction Treatment, published in December of 2024, showed that a telehealth-only platform reduced the risk of buprenorphine discontinuation compared to office-based treatment as usual. This study, published in JAMA Network Open, demonstrates positive outcomes associated with the use of telemedicine. Groups of patients in Kentucky and Ohio had a higher percentage of folks who remained in treatment for 90 continuous days. This article from BMJ Innovations reported that a telehealth model for OUD treatment had higher retention rates compared to industry averages. Specifically, 80% of insured patients remained in treatment at 90 days, surpassing the typical 44% retention rate for in-person treatment. It also showed lower no-show rates of 9.5% of patients missing an appointment compared with the 23% average in traditional in-person settings. So let's talk a little bit about the information that you can gather with a telehealth setting and how it contrasts with an in-office setting. So where is the patient? We say a lot of times we meet the patient where they are, and I think we mean it as like a figure of speech, but with telemedicine, we really do go to where the patient is. Like this might be their home, their work, it might be them walking in a park, but we really do meet them on their own turf, wherever that may be. And that is unique to telemedicine. Usually the patient comes to you, but in a way, now it's kind of like home visits. Or visits at work on their lunch break. I've been able to see patients at their home life, their work stressors, ways that they de-stress. And this gives us very valuable information that we can use to guide the patient. And what are they doing? I mean, are they juggling like 8 kids? Are they on their single 20-minute break of the day? Are they just at home, comfortable on the couch, like that's important information. Let's talk a little bit about the physical exam. Now, listen, I remember how excited I was when I got my first stethoscope. Oh my gosh. I was in medical school. It was great. For me, it was the cardiology 3. Okay, I just had to have the cardiology 3. Learned all my physical exam skills, you know, APTM, all patients trust me, right? You had to remember that for the aortic valve, pulmonic valve, tricuspid valve, mitral valve. Well, with telemedicine, you don't use it, so just forget about it. We don't need it. Sadly, providers weren't taught how to evaluate a patient via telemedicine. But if you remember, the physical exam is just all about observation. And so you were trained in the art of observation. So you're trying to gather enough information. It's not going to be exactly the same as an in-person visit, but you're trying to gather enough information for an appropriately actionable decision. So physical exam, let's talk about the physical exam of a telehealth patient. And it always blows my mind, like how much data you can gather just by observing someone. So remember, this is the objective part of your note. You just write down the stuff that you see, ideally with no judgment, no interpretation, right? So we'll go through a few of these. So general, do they appear well nourished or no? Are they distressed? Are they fidgeting? Are they sweating or shaky to suggest withdrawal? Are they somnolent? Are they sleeping? Did they just wake up because it's the morning? Did they just wake up and it's the afternoon? I've seen that before. Are they slurring their words? Are they slow to respond? I like this because rather than saying, you know, patient is intoxicated, say what you see. Patient is slurring their words, slow to respond, responds appropriately. You know, these are important things to write down without the interpretation of saying this person's just intoxicated. HEENT, are their pupils constricted or dilated? Is there any tearing, dry eyes, rhinorrhea, sniffling? Is there any scleral icterus to suggest liver disease? Is there any proptosis to suggest thyroid disease? You know, do the external ears and nose appear normal? You can tell if the mucous membranes are moist. Respiratory, is there any respiratory distress? Are breaths labored or shallow? Is there any tachypnea? You can see this just by talking to them. Skin, can you appreciate any piloerection, goose flesh? Are there any rashes evident, any track marks, any jaundice to suggest liver disease? Neurological, are they alert and oriented ×4? Do they seem confused? Hematologic, is there bruising or lymphedema? And then psychiatric, you can ask about mood, but remember, mood is different from affect. So mood is the patient's internal experience of emotions, and affect is their outward manifestation of mood, which you should document. So you can write down they have a withdrawn or labile or flat affect. Again, just document what you see. How many minutes in am I? I'm not trying to go too far over here. Anybody?
You have about 10 to 15 minutes left, Dr. Mumm.
Oh, that's great. I'm
Yes.
like flying. This is great. So here's like I don't know, this is a basic normal physical exam of what you can tell on a telehealth patient. Patient is awake, alert, well nourished, no acute distress, pleasantly conversant. Pupils are equally round and reactive to accommodation. No tearing, no scleral icterus, no rhinorrhea or congestion. External ears and nose are normal, moist mucous membranes. No respiratory distress, no tachypnea, normal effort of breathing, no audible wheezing. No piloerection, contusions, or rashes. Skin appears dry, no diaphoresis, no track marks, no jaundice. Patient is alert and oriented ×4, not slurring words, no speech difficulty or stuttering. Patient responds appropriately. Gait, I mean, I don't always have my patients walk, but gait is huge. Gait involves your brain to speak to your spinal cord, to speak to
Is it just me, or I think we've lost Dr. Mumm?
oh, I don't know.
You just came back, Dr. Mumm. Yeah, you froze for a little bit.
Where was I? We'll just pick up at hematology.
You were telling about gait.
Oh, gait. Well, gait's important. It's great. It like connects everything. So let's just move on. No bruising, no lymphedema. Affect is congruent with situation. Patient has a calm and relaxed demeanor, good judgment and insight. This is basic. I mean, I just wanted to show something that we can easily put together with a telehealth visit. Okay, so let's talk about some different care models. So whether you're part of a large health system or a small practice, there's a model that can fit you. The hub and spoke model is the first model we'll talk about. This arranges service delivery around a centralized, resource-rich hub. And this hub gathers together multiple other smaller practices, and they give training, facilitate resource sharing, provides needed specialized expertise. So this is like what Be Well does, right? This is the hub and spoke model. The in-person model, this is what we all grew up with, right? This is the OG model. You have your local doctor, doctor's office treating patients. And then a hybrid would be like some kind of a mix. So a hybrid is where the in-person model meets the telehealth model. You could have a specific room set up in your clinic that is only for telehealth visits. You should have your computer set up and ready to go. I would have a dedicated computer, not something that's shared that you carry around from room to room. The lighting should be appropriate so that people can see you well. Ideally, you'd have multiple screens or monitors so you can chart at the same time that you're talking to the patient. And then virtual first practices. This is kind of what we ended up doing. And you'll need a lot of different tools for a virtual only kind of practice, but it's usually different like software to coordinate with patients and your team. I would like to say as well that the telehealth model doesn't only involve prescribers. It involves the coordination of counselors, therapists, case managers, pharmacists, peer support specialists. And I like to say that it's really a team sport. So sometimes keeping a practice together just feels like herding cats. There are a ton of options to help your team perform like a well-oiled machine. You can, of course, do phone calls, text messages, and emails, but there's different software that makes you feel like you're in the next room from your coworker. We use something called Trello. It's like
We'll give Dr. Mumm a moment. It looks like he froze again.
oh no. Oh
Do you
no.
guys use Trello, Dr. Mumm? That's
Yeah,
where you left off.
okay, yeah. So we use Trello. It's a Kanban style organizational hub. We have different boards for, just the providers versus the kind of ancillary staff, counseling, etc. And it helps you stay on track and communicate well. Teams is a great choice for face-to-face meetings. Google Calendar can be extremely powerful for linking people together and having all your schedules align. And then there's Slack. A lot of people have heard of Slack. We don't use it, but it's a cloud-based messaging platform for workplace communication, organization, and sharing files. Other software, we didn't even talk about the EHR. This should be EHR, not her. But ideally, you would have an EHR that can prescribe controlled substances. Obviously, it needs to be HIPAA compliant. This provider to patient software, we like Doxy.me or Doximity. So these are encrypted end to end so that you can see the patient. And it's a HIPAA compliant software, so you can talk to the patient. The patient doesn't have to download an app, so it's great. They get a text, you click on the text, and boom, you're in this like end-to-end encrypted environment. So our patients tend to love it. I just wanted to make a mention about phones. Cloud phones seem like a really good idea, but they're not. Just don't do cloud phones. Just use a regular phone, a regular cell phone, or a landline. If you do a cloud phone, there's always this drama. Sometimes it doesn't work, whatever. It's the cloud, lightning strikes, whatever. It's not going to work, and it's no good. So just do a regular cell phone or a landline. I wanted to touch on the DEA and COVID flexibility. So this is kind of like a moving target right now, and we're not exactly sure what's going to happen, but currently we're still under the COVID era regulations for prescribing controlled substances. This should remain in effect until the end of this year, and that's when the final rules go into effect. And I love to say like final rules with quotes because they always seem so final until like a week before. And so then oftentimes because it's, government stuff, they kick the can down the road. But we'll see. We don't know what's going to happen, but according to the final rules, we will have these like telemedicine flexibilities for the long term, but you have to see the patient in person within 6 months somehow. So it seems like that's what's going to happen. And I just wanted to touch on that because I figured somebody was going to ask about that. How to begin? You don't have to build a massive program overnight. Start with a few patients, refine your workflow, go from there. Start small and iterate. References and discussion questions.
Thank you, Dr. Mumm. That was excellent. Yes, I'd like to open the floor for any questions anyone in the Learning Network might have for Dr. Mumm.
Dr. Wong, I had a question with regards to panel sizes, because I think at once upon a time there was a thing about like how much of a panel size you can have for people who are on Suboxone or controlled substances. Is there any such restriction still in place, or you can have as big or as small a panel size as you want to?
How many patients you can carry at one time, right?
Yeah.
Yeah, that's no longer, when they got rid of the X waiver, they got rid of that too. In fact, before they got rid of the X waiver, they were like, well, you still need an X waiver, but you can have, like, they upped the limit. And then once they upped the limit a couple times, they just totally got rid of the X waiver. So there's no limit to how many patients that you can carry at one time. Anybody else? Does anybody do this, or do they have like different perspectives? Does anybody think I'm totally off base on some of these and they really love cloud phones and they think I'm just being silly?
Hi, this is Dr. King. I'm sorry I joined a little bit late. So
Hey.
how do you handle your urine testing?
Right. Yeah, I kind of anticipated that question. So we send them urine drug screens through the mail. And they have to complete their urine drug screen. And people are like, well, they could just lie about it. And I'm like, yeah, they could go as far as you can lie about urine drug screens in an in-person setting. In fact, if you look it up on Amazon, they sell devices where you could get away with an in-person observed urine drug screen. So it depends on how far you want to go. I feel like if a patient wants to lie about something, they're going to lie about something. So we send it through the mail.
Another context specific question I really wanted to ask was with regards to Texas was we do have like a significant portion of Hispanic speaking population. So like in terms of translation services, like do you have integrated services, or like what have you found useful?
Yeah, so the answering service that we use also provides a translation service. And so it's almost exactly like if you're in person and you pull out your iPad and there's another person there to translate for you, it's almost exactly like that, but it's like a three-way video. So it depends on what service you use. Dr. Rezada gave me a reminder. Hey, on the urine drug screens, we have a saliva drug screen as well that you can't really fake because you're doing it in person, but it's a balance because they're not quite as accurate. But I think if you just kind of randomize some saliva tests in there, it kind of keeps people on their toes, keeps them truthful. But the saliva ones aren't really that great. I still say use some sometime.
So you send the urine, what do you actually send?
We send a drug screen, either the saliva one or the strips that they have to pee on.
They, so somebody looks at it or somebody looks at them? Okay, okay.
We don't do observed urine drug screens.
Does anyone on the call have experience with the DNA confirmed urine drug screens where you submit the swab and then they match the urine to the person's genetics? I know that there are some companies that are out there doing that. They tend to be a little bit on the pricier side, and so having access to those is not necessarily equitable or across the board.
Yeah, I'm not sure who's going to pay for that. Seems like in a research kind of context that might be, helpful. But yeah, if we want to treat a lot of people, that's going to be. I can't imagine that that's cheap yet.
And wouldn't those have to be sent off to a lab for like lab confirmation or something, I'm assuming?
Yeah, so the way that they work actually, I mean, and some of them are not to get completely off track, but some of them are tied with your phone, so you can actually take a video of yourself doing the swab and then have that uploaded and confirmed by people, and then they match the DNA swab to the DNA that's found in the urine at a later time. It tends to be, I tend to see like a lot of people advertising for these things at like the Federation for State Physician Health Programs, for example, where drug testing is like a big part of the oversight, but I didn't know if anyone on the call had any experience with those.
I love this conversation because oftentimes it turns into like it a lot of times can turn into like we got to catch them. Like we got to catch somebody in their lie, And I got to remind myself a lot of times like I'm not the police. Like, yes, there are some programs you've got to know, like you got to know for sure. But I remember when I did the X waiver training, SAMHSA's take on it. SAMHSA was like, if they divert buprenorphine, I mean, it's not like diverting, you know, hydrocodone or oxy or fentanyl. Like it's usually, and I have studies to back this up, but I didn't know we were going to talk about this today. But usually when they're diverting, they're giving that medication to someone else that wants to feel normal. They're usually giving that medication to someone that needs to get to work today and do their job normally. They're usually giving it to someone who wants to be in recovery. And patients that buy buprenorphine on the street illegally usually are taking it because they want to be in recovery. Oftentimes, fentanyl is going to be even cheaper than buprenorphine. There's another study in France, and again, I don't have it, but I could send it later, where they pretty much flooded their streets of this area with buprenorphine. And guess what? Less people died of overdoses. More people take care of their lives and their families. And so there's like this balance, I feel like, because yes, it's a controlled substance. And by the way, I don't condone diversion, but you've got to balance this. You've got to balance that this is a medicine that actually saves lives. This is a medicine that they take and they won't overdose on fentanyl and die. And so it is very much a life-saving protective medicine. And so I just wanted to throw that out there because this discussion on urine drug screens always kind of turns into this. And my position is I'm not the police. I'm not here to put you in jail. If I find out you're diverting, obviously this is going to be a real problem with being in our program. But I'm of the stance like we're going to help you the best that we can. We're going to reach you. I don't care if you're in El Paso or the Valley or Houston or whatever. We're going to help you as best we can.
Thank you, Dr. Mumm. Jose, I see your hand is raised.
Hi, yes, good afternoon. Do you know, Dr. Mumm, of any low-cost telehealth options for Suboxone for patients that are uninsured or underinsured?
Well, yes, I think so many of us here in the call, we work with Be Well, and so we're an option.
Okay.
Anybody that's connected with Be Well, I think like if you messaged, Jasmine or Angela, they would connect you with a ton of resources that are close to you.
Okay, perfect. Thank you.
Mhm.
And just a quick plug for OSAR, outreach, screening, assessment, and referral. Every region in Texas, there's multiple regions. You can look up what region you're in, find your OSAR and call them and ask, what referral sources do you have and which one of them offers telehealth options? Because there are more out. Be Well is fantastic. Absolutely support that. But there's more options than that as well. So your OSAR is going to have a collection of all of them with these take Medicaid, these take Medicare, these have grants, these have these private insurances. They're going to have a database for you. So reach out to your OSAR. Just type in OSAR Texas and it should be able to show you where to go. I'll pop a link in the chat.
Thank you,
Perfect.
Dr. Walker.
That was wonderful. And thank you, Dr. Mumm, for that Be Well Texas plug. We are a great resource for all of you all. So please contact us if you need more information. In the interest of time, we will move on to our next portion of the session today. But thank you again, Dr. Mumm, for your wonderful presentation. And to everyone that has shared resources, Dr. Walker has dropped a couple here in the chat. So please refer to those and save them on your browser and refer to them later. We will go ahead and move on to announcements, but before we do, please, Dr. King, if you could just introduce yourself real quick. I do see that you joined, and then we'll move on to Dr. Weems for a brief introduction as well.
Okay. Yeah, sorry, I ended up, I thought I had a clinical meeting, but it ended up being canceled, so I was able to come, which was good. Anyway, I'm Dr. King. I'm a professor of psychiatry here at UT San Antonio, and I'm the medical director of Be Well Texas. Thanks.
Thanks, Dr. King. Dr. Weems?
Yeah, I'm John Weems, internal medicine doc and addiction medicine specialist here at Community Care Big FQ in Austin and at UT Telemed with the Shout team. Great session, and I'm looking forward to the case.
Excellent. Thank you all, gangs all here. So we'll go ahead and move on to our announcements. Karen, if you can share those slides, please. Thanks so much. To claim your CME credit for today, you must text by midnight tonight. Text attend 100-985-38 to 844-502-1338. Next slide, please. Do you have a difficult case that you or your team have encountered? CSTAT offers you and your team the opportunity to present any challenge your organization is encountering and receive feedback from our hub of experts and the broader learning community. There is no need to prepare a formal presentation as we provide you with the case form to fill out in order to assist you with your case presentation. So please email us at cstat@utesca.edu for further assistance if you're interested. Next slide, please. Thank you. Join us for our maternal health echo program on Tuesday, May 6th at 12 p.m. Central Time. This program will equip perinatal healthcare providers with the necessary training, consultation, and support to enhance care delivery for pregnant and postpartum women experiencing substance use disorder. Please register using the link in the chat. The Center for Substance Use Training and Telementoring, also known as CSTAT by Be Well Texas, is still accepting applications for our MOUD mentoring program. Join us for an exclusive opportunity for prescribers to receive personalized one-on-one mentorship to integrate MOUD services into your daily clinical practice. This exclusive offer is available to a select few in the Texas Public Health District Region 8, so don't miss your chance. And to take advantage of this wonderful opportunity, please visit the link that is in the chat or reach out to us at cstat@utesca.edu. Next slide, please. And finally, please do join us once again for our next session on April 24th for a session on reimbursement strategies for SUD medication services. Thanks, Karen. And so before we move on to our case for today, I'd like to remind everyone that no protected health information is allowed in either the chat or our discussion, and let's continue making the space inclusive and open to respectful dialogue. So with that, Dr. Rosada, once Karen shares the case, please walk us through it.
Hi, everyone. My name is Miles Rosada. I'm a physician at Olive Branch Recovery, along with Dr. Mumm, who just gave the presentation earlier today. I brought a case today about cannabinoid hyperemesis syndrome, and I just thought it was an interesting case. In our clinic, I feel like, well, actually, I've been a doctor here for 11 years now, and I feel like over the past 11 years, I've seen an increased use of cannabis in patients and an increased presentation of cannabis hyperemesis syndrome. And so I thought that might be something interesting to talk about. Our clinic is seeing this 29-year-old male who came in with wanting help for substance use disorder. Particularly, he was using marijuana. And a couple questions I wanted to address today was, why are we seeing more cases of cannabis hyperemesis syndrome? Like I said, over time, I felt like at the beginning of my career, it's just something I rarely ever saw. And now it's something that I feel like on a monthly basis. Another question I wanted to address was why it might be difficult for someone to accept that cannabis is the cause of their symptoms. A lot of times when we talk to patients and mention that their marijuana use could be the cause of their nausea, vomiting, and how they're feeling, they seem almost like in denial that that could be the case. And then the third question why is cannabis, which is actually used as an antiemetic, especially in cancer patients, why is it leading to these excessive vomiting symptoms that people are having? The 29-year-old male in our clinic has been using marijuana multiple times a day for the past 5 years. He did not believe initially it was due to his marijuana use. He thought it was maybe a peptic ulcer disease. He actually ended up vomiting up blood at one point as well. And he got evaluated for some type of GI bleed. He had an endoscopy done and everything looked okay. They said he had a little bit of mallory-wise tears just from the forceful retching. And all the workups he had in the hospital were all negative. And he finally came to accept that maybe it was from his marijuana use. When he came to us, he just wanted help with his symptoms and trying to help get off of marijuana. And a couple of things about him, like I said, he mentioned he lives with his parents, no kids. He also has a diagnosis of ADHD and anxiety, depression. Takes Adderall and fluoxetine as well. And so what we talked to him about was really in the short term, what are the treatment options when he is having these symptoms? And usually it's going to be fluids. This could be oral fluids. It can even be IV fluids if he's at an urgent care on ER. It's antiemetics will help as well. One medication we found a lot of use with or help that's helpful for these symptoms includes Haldol. Some people say that hot showers helps with their symptoms, capsaicin cream, proton pump inhibitors, and pain control. Unfortunately, there's not really much harm reduction I feel like we can do with this population as the treatment's really just kind of complete cessation of marijuana. And a couple things about marijuana, why we think that they do cause hyperemesis is the CB1 receptors, which are located in your brain and your gut. They get activated and with marijuana and actually initially help with nausea symptoms. So you feel better initially. And then when you have chronic and constant use of marijuana, which is lipophilic and gets deposited in your fat, it can slowly leak over time and just lead to downregulation of those receptors. So you end up getting delayed gastric emptying, get nausea and vomiting symptoms. And we think this is what causes the cannabinoid hyperemesis syndrome. Like I mentioned, THC does build up in tissues. And even though you may have quit, a week ago or a few weeks ago, some people are still coming in with nausea and vomiting. And just because it slowly releases over time, that's why those symptoms can be prolonged. And then one thing that patients say do help with these symptoms are hot showers. And this is theorized to be due from the TRPV1 receptors, which are upregulated with marijuana use. And they're saying that hot showers and the topical capsaicin cream can help with those receptors and help from being activated. But I thought it was an interesting case that we're seeing more of that in our clinic, which I feel like was really unheard of maybe 10 years ago. And just wanted to bring it up and see if other people had similar experiences or they had other takes from the symptoms as well.
Awesome. Thank you, Dr. Rosada. And at this time, I'd like to open the floor for a case discussion. Are there any questions or comments for Dr. Rosada on the case?
Dr. Rosada, just out of curiosity, is the I guess statistics different between smoking it or taking like oral medication, the marijuana?
I think just heavy use in general can lead to it. I think most of my patients that we see smoke it. I know
Yeah.
it's legal now in a few states, and I think one of the reasons that we see it more often now is that there's been, I think, a better general acceptance of marijuana use. It's now legalized in some states as well. And then on top of that, I think the concentration is
Absolutely.
higher now. And a lot of these, 10 years ago it may not have been as strong, but today it's much more strong.
Wow.
Those doses. And so I think that's kind of led to these increased Kenvo hyperemesis syndrome that we're seeing a lot of.
Right. I was thinking along the lines of the nausea and stuff, because repeated coughing and that gagging from smoking, the respiratory part of it could be I don't know, more damaging than just taking, I guess, the oral gummies or something like that. So
yeah, there's probably more pulmonary side effects from smoking it.
Yes, sir. So I'm wondering if maybe if that's if there's a difference in reactions to that from smoking a lot. Like you said, excessive smoking can be very, very damaging too. Even though it's helping in one way, it's really, really damaging in another,
Sure.
I don't know. This I would kind of like lean towards that, like towards explaining to the client that, look, that excessive smoking is going to cause nausea, it's going to cause all these things versus maybe possibly taking the same dosage but orally.
Yeah, I imagine my suspicions maybe due to the dose amount you're taking, but like I said, most of our patients that we see when we ask how they get it, they said they smoke it typically. And so I don't have a comparison which one is
okay
against each other, but I definitely, if you smoke it, you definitely have pulmonary issues as well, potentially developing COPD and shortness of breath and lung damage, things like that.
Okay, well, that's pretty much what my question was.
Thank you, Jeffrey. Oh, go ahead, Dr.
Towards
Charlie.
that, sorry about that. Towards that, I just wanted to make this point. Like, first of all, I shared this information sheet from NIDA that shows the potency of cannabis over the years, which shows that back in '95, like the amount of THC, which is the psychoactive compound, and there was close to 4%, not even. And now the potency has risen to the point where it's almost 16%. So it's like 5 times as more potent. And this is just the bud that we're talking about. And if we're talking about vaping, the THC vapes have like THC that's like more than 90% in there. So it's completely a different drug from back in the days. So that's something that might contribute to the increased incidence of cannabinoid hyperemesis that we're seeing. One question I had for Dr. Raizata was how's the control of anxiety and depression in this patient? Because it seems like he is on fluoxetine, a relatively low dose. So how's the control of anxiety and depression at this point?
He seemed a little bit anxious. He denied any depression to us, but a little bit of anxiousness. But he felt that it was well controlled with the fluoxetine. When it came to ADHD, he said he was doing fine with that. And so, but a little anxiety for sure, but no depression at the time when he visited with us.
I have a comment. So I treated a patient with hyperemesis once, and it can be pretty severe. She was unable to keep down fluids, and really she didn't get treated that well at the emergency room. Even though she came in with her family, she was, I don't know, think she was like 18 or something. She was just a late teenager. But I convinced her that it was a bad idea. She stopped, her symptoms went away. And then she showed up in the clinic again, sort of retching and all this stuff. And what had happened is she was still having, a little stomach upset. And her friend suggested to her that she try CBD and that this might be something that would be helpful to her. And of course, any of these CBDs have, THC in them, to some percent. And obviously, even that relatively low dose, well, who knows how much it was because, it's not, really accurately determined. But whatever she was getting in, some vape shop CBD, preparation was enough to trigger that vomiting again.
Yeah,
Yeah, I'd like
presentation
to
can be very
second.
violent for sure. The patient was vomiting up blood and ended up getting endoscopy, so that it can be definitely severe presentations for sure.
Yeah, I was gonna second or third that, Dr. King. These patients look like they are dying, like they look awful. We've had a ton of success with droperidol rather than Haldol. I mean, Haldol, yes, does work, but droperidol is also very nice. And then I'll just second also, yeah, like it's one of those that, I feel like your second, third, eighth, 10th time in the ER coming in with cannabinoid hyperemesis, and it is a very persistent, they don't believe you. They're like, no, that's not what this is. But I think that kind of leads to some of the eye rolling and the not treating them well, which is, again, we're just talking about stigma, right? So, but I would say these patients have a problem just like any other patient with any other substance.
Yeah. And I think one of the reasons that it's difficult for them to make that association that, this is what's causing it is because there is no temporal association with the consumption of THC and the cannabis hyperemesis, right? So the hyperemesis is cyclical in nature and it doesn't happen when you smoke. It happens if you have cannabis in your system, right? That's what it is. So it's difficult to form that causal association because it's not linear. And the other thing is that it takes a little while for cannabis to actually wash out of your system. So you can't really see the benefits from like a week of abstinence. You really need to be abstinent for a while to see any benefits, and that's kind of sort of why most of the people just like revert back to use because they've been away from it for a week and it didn't help. They still had some vomiting going on or still had that bouts of like nausea showing up. So it's just that it's difficult to form that causal association because
Dr.
it's not
Chalk,
instantaneous.
you're right. There was a case study of a patient in Colorado, of all places, that she stopped smoking marijuana and she had this violent vomiting for 2 years. 2 years until her body figured out this new normal. And so I tell my patients that all the time. I'm like, you just have to stop and you have to wait. That's your body doesn't like it for some reason. And so that you're totally right about that non-temporal association. Imagine waiting 2 years to stop vomiting. I would just be not happy.
I do see a question in the chat from Megan Clark. She's asking how much marijuana was this individual using?
He smoked pretty much all day long. From the minute he woke up to when he went to sleep, he just smoked all day. He'd been doing that for multiple years. And so I would say extremely, extremely heavy use. I don't have the exact amount he was using though. I didn't document that or ask him the exact amount, but when he told me he was smoking all day long, it gave me an idea of what the amount.
I have a follow-up question, if that's okay.
Yeah.
I'm Lori Metz. I work at, I'm a nurse practitioner. I work at Karma Health in Austin. And we focus on SUD services and primary care. So I see people for, with SUD issues all of the time. And I am seeing a lot more people coming in with like issues related to cannabis use. And I'm just curious if anybody on this call has any kind of words of wisdom or like special techniques they use to kind of like open up the conversation about cannabis use. What I find is that so many of my patients, they use it a lot, are saying that it helps them with their anxiety. And at the same time, they, like your patient, like may also be on, medications for anxiety and have a history of anxiety, documented history of anxiety, and present with anxiety symptoms. And to me, I'm always curious, wanting to know more about like, is the THC, is the cannabis like actually helping your anxiety or not? And I try to have that conversation with them, with that curiosity, and I say things like, we have great evidence that it may help with certain like, physiologic conditions, but maybe not so much, or it's not clear that it helps with any kind of like mental health issues, and it may be harmful. I'm just curious, like, because we're seeing this so much, like if anybody else has any good kind of like ways they just like open up that conversation with people.
I think one of the things I would say in this, and this is a good question because this happens very often. So one of the good ways of doing it is first of all acknowledging that whatever they feel like, if they feel like their anxiety is getting treated from it, maybe it's just that they are avoiding the withdrawals of cannabis, which is like one of the symptoms of withdrawals is anxiety. But for them that's true, and it's okay to acknowledge that maybe you're feeling some relief when you use cannabis, and then offer alternatives. Because if you don't offer, like, I think that's an important thing, that you have to give them something, or you have to build upon it. You have to play the long game where you're offering them alternative, whether it be in the form of medication, like optimization, or it be in the form of like teaching them skills to deal with stressors better in life, or be it in the form of therapy. You have to offer an alternative, and make them feel like they can feel the same, or they can feel better even without using that substance. Because if you just start with the cessation person and there's no alternative, then they're like, but I have that and I need to fix that.
Yes, of course, I hear that, of course.
The other thing is that impressing upon them the fact that maybe it's like helping with your anxiety, but it's also causing all these other side effects that you're coming in for. Like, the hyperemesis is not like a fun thing to have. Like, so, and if like, use of cannabis or use of any substances is not just the use of it doesn't mean like you have an addiction or you have a substance use disorder, but use in situations where it's impacting your, like, psychological health or your physical health, and just keep on using even with those side effects that you're having, that might signify that there might be some problematic use.
Thank you.
Yeah, I had to. I'll echo what Dr. Chaudhry says. So I find that oftentimes seeing people on a pretty regular basis, and then just listening for opportunities to sort of drag that in, seeing somebody on a quarterly basis, you're not ever going to have an opportunity. But and even monthly can be a bit difficult, to get to the place where you can talk about that. I guess if somebody's seeing a therapist, maybe the therapist, if they're seeing them more frequently, might have more opportunities. But yeah, I think that I'm also convinced that really it's not a good treatment for anxiety or depression. And in fact, it tends to worsen those things over time. Just, and if you're convinced, then you can be somewhat more persuasive, given the right circumstances, with those patients. So, I agree. It tends to be more of a long a long-term kind of thing. But you know, one of the things that may be helping us in the long run is there is more awareness now that more people are using and more people are having adverse effects from their chronic marijuana use. I think you know, it is more in the you know, more in the news than, you know, than perhaps it was before there was legalization and stuff. There was a lot. I mean, there still is a lot of romanticization about, you know, marijuana use, CBD, it cures everything. But really, there's except for those very few conditions, and it doesn't even help a ton necessarily. You know, they're more likely to be interfering with their anxiety. And this guy that's smoking marijuana all the time and taking a bunch of Adderall, I mean, you know, the marijuana is going to be interfering with his, you know, focus and attention with things. And he must have been spending a ton of money. You know, he's living with his parents. I mean, he's spending all his money on his marijuana use, and that's you know, so you know, what's he thinking about in terms of his productivity, his life, his independence and things? I mean, 29 years old, you know, many people are thinking they want to be more independent in life. So I think there's some of those things that you know, might be worthwhile, you know, trying to bring into the conversation, and you know, might be helpful and motivating.
Yeah, I hear you. Thank you. I think, yeah, I'm hearing a lot of just like long, yeah, conversations over time, and just listening really carefully to, you know, their expression of if there are consequences for them, and kind of echoing those back to them.
Those
Yeah.
those you know, decision rulers in MI and things like that, just like, you know, you know, are you willing to try, you know, like a different you know, a different path for yourself here? Maybe you'll get, you know, your life goals accomplished.
Thank you, Lori, for unmuting and participating and sharing that question that sparked some more great conversation. And thank you all for sharing your resources and insights and personal experiences, especially in clinical practice with patients that use cannabis. In the interest of time, I do want to give the opportunity to Dr. Chowdhury to give us a summary of recommendations for today's session, as there were many. And so, Dr. Chowdhury, I give you the mic and the task of summarizing for us today, please.
Thank you so much, Angela. I think the presentation today was very insightful and also very important for us. As Dr. Mumm mentioned, that Texas is greater than 80% rural, so we have to provide care to these people who don't have access to substance use care. And we've seen time and again that telehealth care is associated with better retention, equal if not better outcomes, and better engagement by patients. So it's definitely imperative that we get well versed with how telehealth works, and we have to understand it's most of the same doctoring and healthcare skills that we have learned. We just like adapted to this new technology. Dr. Mumm really talked about some of the differences in the physical exam aspect of things, because that's one of the most contentious things that the traditionalists think, that, you know, it's difficult to perform a physical exam. That's why it's not a good modality, but we can do so many things in terms of the physical exam in telehealth. And the only thing we're limited by is like kind of sort of touch, right? The important thing for telehealth, providing good telehealth care, is that you have your preparation. So like you have a good EHR system, good video conferencing system. You have options for interpretation, that especially in the context of Texas, and then a good video setup. I think it's horrible when you're seeing a doctor and you can't see them clearly, or they're cutting off or something like that. So it definitely helps make this experience a little seamless by providing by having some preparation. And then we have to not forget that this still is a team sport. So all the other aspects of healthcare, all the ancillary support, they all play an important role in telehealth. So that was kind of sort of the gist of the didactic session today. And in terms of our case presentation, it was a very interesting case presentation, something very near and dear to me, things that I see very often. So cannabis use is definitely on the rise, and this might be one of the reasons that we are seeing. And so to answer the first question, this might be one of the reasons we're seeing a rise in cannabinoid hyperemesis syndrome. And the other reason might be just because the landscape of cannabis has changed over time, where the psychoactive compound has been selectively bred to be more, like 5 times as more than like 20 or 30 years ago. And then with the advent of like vapes and stuff, which are 95% or 90% THC, it's just a different drug. So that's why the proportions of CHS, or like the cannabinoid hyperemesis syndrome, has just skyrocketed over time. The other question was about why is it difficult to accept that cannabis is the cause? And I think one of the main reasons is that temporal association. You do not get that immediate negative feedback from, like, you smoke cannabis and then right away you have nausea. It doesn't happen like that. And because the nausea itself is cyclical and not associated with the use of, like directly associated with the time of use of cannabis, people don't form that causal association. And that's what leads to, like, people not believing that might be the cause of their cannabinoid hyperemesis syndrome. And the other thing is that abstinence doesn't immediately show result. So you have cessation of use for a certain period of time before you start seeing improvement. And that's why we see that there's a difficulty in accepting that might be the cause. And to the third question of why, when cannabis is sometimes used for nausea control, that it causes cannabinoid hyperemesis syndrome. And it's to do with long-term use, because over time, when you use it long-term, the receptors that are responsible for decreasing the antiemetic activity of cannabis, they get downregulated. The CB1 receptors get downregulated, and the receptors that are implicated in causing nausea, they get potentiated, and that's what leads to the syndrome itself, where long-term use downregulates the antiemetic receptors and upregulates the proemetic receptors over time. And that's what we think it is, but we don't know for certain so far. Just like many things in healthcare.
Wonderful. Thank you, Dr. Chowdhury. Thank you to everyone for your participation today. As a plug for a session in the future, in June, we will be continuing the conversation on cannabis use on June 26th. So please reference that flyer that Jasmine shared in the chat. And so thank you everyone for joining and attending today's session. As a reminder, to claim your CME credit, text by midnight tonight. Text attend 100-98538 to 844-502-1338. And we also kindly request that you complete the post-session feedback survey using the link in the chat. Thank you, everyone, and we look forward to seeing you all at our next ECHO session. Have a great rest of your day.